Well, our next speaker is Professor Christoph Nienaber, consultant cardiologist at the Royal Brompton. He runs the adult Marfan Clinic. He has done a lot of pioneering work on stenting blood vessels and even stenting the aorta in Marfan syndrome, which is a very tricky thing because the wall is not as strong as an ordinary person's. So I'm hoping he's going to tell us a little bit about navigating the transition from the pediatric to the adult Marfan clinic. At the Brompton Hospital, the doctor who runs the pediatric clinic is Dr. Nitha Naqvi, and she has spoken to Christoph and they have written this talk together. This talk came about because sometimes the transition from the pediatric clinic, where one type of care is being established, to the adult clinic, where the care may be slightly different, is not smooth. We're fortunate at the Brompton in that it is very smooth and cooperative. So Christoph's going to tell us how to do it. Is Christoph here?
Yes, can you hear me?
Yes, perfectly.
Okay, I was just setting it up. It's coming up in a second. First of all, want to thank the Marfan Trust in the UK and you personally, Anne, for inviting me to this meeting. It was really fun to prepare it and to share some experiences in the last couple of years with the audience and with you, of course, and I hope that we can discuss a couple of issues later.
Well, thank you for that. We're going to try and use your article in our next newsletter and also put it on our website because it is an area we get asked about. It's a strange time of life. You know, the children are off to university. You may lose them to follow-up. So it's really important to get it right.
So I'm Nitha Naqvi. I'm the paediatric cardiologist who works with Christoph. Are you able to hear me?
Yes, thank you.
Okay, great. So we're lucky at the Brompton because we're all on one site. So the transition is quite smooth and we don't have the challenges that many hospitals do, that notes and MRI scans and everything are in different units. We have everything on the electronic patient record and that's easy and that's smooth. So arranging the transition in that respect, we're very lucky. And we try as much as we can to have the appointments in a family clinic. Often that's difficult to organize, particularly with the COVID, I have to say, but we have Christoph in one room seeing often the parents and I'm in the next room seeing the children, and that does mean that when the children get older and transition to the adult care, it's actually all in the same place. So it's not such a big change because it's all familiar. I totally support what you want to do, Anne, working on the psychosocial support for teenagers and young people. I had actually planned to do a transition Marfan day for young people. And I've actually managed to get some funding for that from our charity, the Brompton Fountain. And unfortunately, because we've already done one for the congenital heart disease patients at Chelsea Football Club, and I thought I could do something similar. And unfortunately, that's all been postponed because of COVID, but we know COVID is going to end. And when it ends, we do plan to do that for sure. And I hope that I'll be able to talk to you about it, Anne, and open it out to young people with Marfans on the wider scale. We actually at the Brompton have a youth forum where young people get to meet with each other and talk with each other. And pretty much it's been the congenital heart disease, but it is open, of course, to young people with Marfan. And I think they will have much more in common with each other. So that's something we'd be keen to be looking into in the future. Is Christoph on?
Yes, can you hear me now?
Oh, great, Christoph. I'll stop speaking now. I was just...
Carry on, carry on. No, no, no.
Thank you, Christoph.
Use your time, please. I'll follow suit.
Show you. Thanks for that, Nitha. That sounds really exciting. We'll look forward to that.
First of all, thanks to the Marfan Trust and you in particular, and to offer me the opportunity to share our thoughts and to talk a little bit about our experience in the last couple of years here in Brompton. I'm talking about the transition clinic, and fortunate my PA will also join in and give you some thoughts from her end. And then finally, in the second part of my presentation, I will talk a little bit about some new technology that we can use in the setting even of Marfan or hereditary connective tissue diseases. Well, we all know, and this is a slide that I like to share with everybody I'm presenting some sort of Marfan related data to. This is 20 years, more than 20 years ago. And the group in New Haven presented that, you know, genetic underpinnings in the presence of an ascending aortic aneurysm is something to look for. I think Stuart in his presentation this morning mentioned it very elegantly, that the combination of clinical features, family history, and genetics or genetic testing is the way to success and the way to a proper diagnosis. But as we know, based on family history and our findings and experience, Marfan in particular is a family affair. We have spent hours and have listened to interesting talks all day on the fact that any kind of hereditary condition, particularly affecting the cardiovascular system, is a family affair. It's a congenital condition. It manifests in newborns in severe cases. It's present in children and adolescents. And of course, it affects the various systems, the orthopedic system, cardiovascular in particular in terms of prognosis, ocular issues, we learned about this from Anna earlier today, and psychosocial issues, as we just heard from Dr. Benninghofen. This is a picture of an adolescence that basically tells you important information. It shows you on the left-hand side the presence of a Harrington rod to correct scoliosis, and on the right-hand side a mildly dilated aorta, even in a person that is not even reached its 16th year of life. So it shows you the most severely affected systems in the body, the orthopedic system or the skeletal system and the cardiovascular system are most likely to be affected and are most likely to have a serious effect on the later life. A later life, particularly with regards to the cardiovascular system, is threatened by the formation of aneurysm, dissection, aortic valve regurgitation or dysfunction, and mitral valve degeneration. And Prof. Pepper this morning has talked about various issues related to surgical care of these cardiovascular manifestations. But beside the cardiovascular manifestations, the before mentioned skeletal, ocular, lung and neurological issues need to be mentioned as well and should not be forgotten. That's why, besides the fact that we should look at affected patients in early age, in childhood and adulthood, not only from a singular perspective, but from a multidisciplinary perspective, addressing all these various organ systems. And this is a slide that I like to show to you because it is 23 years old, when our team at the time in Hamburg, and that was mentioned by Dr. Benninghofen already, set up the first Marfan clinic in the Hamburg-Eppendorf hospital environment, involving various disciplines, as I mentioned, orthopedic surgeons, neurologists, gynecologists, even pediatric specialists, cardiologists, etc. And we followed patients from childhood to adulthood to in various intervals, usually in intervals of 1 to 2 years. And we found that this information actually needs to be identified and communicated to the entire family from early on to adulthood. And this gentleman on the right-hand side finally is shown at age 30 or so at the time. So that concept, which was put into action 25 years ago in Eppendorf, basically was summarized in this little article in German and was distributed to all GPs in the country, and everybody who is registered in the so-called German GMC, if you want, got access to this little publication, which was summarizing the need for a more global or more aerial view onto the condition of Marfans, particularly to be set up in university environments and centralized there. We looked at, of course, interdisciplinary care in addition to the early look in childhood, because the complications start in early childhood, and the corrective measures can be addressed, and we talked about this all day long, through adolescence to adulthood, in basically meaning that the condition requires a lifetime care. The point is not only to educate and instruct the family, but also to explain everything, to facilitate and embrace the condition. I like the analogy of Marfan to be put on a bus as another passenger rather than a driver. That is a very good iconic picture how to deal with it, probably. If the family understands it completely, we just accept it and live with it rather than let us drive by it. And finally, I think this is an interesting second page of that little pamphlet from 23 years ago that showed the few mutations known at the time, but it already showed to the entire medical community that we not only look at a genetic condition, but a condition that affects various organ systems as listed on the right-hand side. So the GPs 25 years ago in Germany were informed about cases that have skeletal features, ophthalmologic features, cardiovascular, neurological features, in particular also affecting the dura mater. And I want to spend a moment on the dura mater because it hasn't been mentioned all day long, but it is an important part of the body that can give you some early hints from a phenotypic point of view, whether you're dealing with a Marfan condition in childhood or not. So I was happy enough to be part of a consortium of some Italian friends and my colleagues in Eppendorf at the time, and we were able to look at the assessment, at the phenotypic assessment of Marfan syndrome in childhood as well as in young adults, looking particularly onto the anatomy of the dura mater. And we found that the dural ectasia, which is a bulging kind of appearance of the distal dura mater, was a very interesting finding, which was often seen in patients with a confirmed diagnosis of Marfan, even in childhood, even in early adulthood. Here's an example that shows you the various stages on the right-hand side, and you can see from A to D a progressive appearance of dura mater ectasia, which is an iconic signature kind of pathology in patients with confirmed Marfan, as it turned out later. This is some data analysis from this retrospective analysis, and it shows you that an early stage of dural ectasia, coined here as 1, implies patients beginning at the age of 6. So the standard deviation of that whisker plot shows you from 6 to 50, you see dural ectasia in a total of I think 86% of affected patients confirmed to have Marfan syndrome. And this observational evidence was further looked at by some colleagues of us in Eppendorf in the 2000 years. This is led by Christian Habermann, a radiologist with a particular interest in MR scanning of patients with connective tissue disease. And they found out that the dura and the cardiovascular system have a high prevalence of early pathologies in childhood. And they were able to identify it a little bit closer. You see, with a couple of years later, the images got better. This is MR images showing the various levels of the dura mater, and they concluded that L5 and S1 levels and the sagittal views are the ones to look at to analyze it in quantitative ways. And they found that out of patients confirmed with Marfan, 86% at early age already showed this abnormality or this finding, which eventually was part of the newer gent nosology and is now an important criterion to look at. It's often forgotten, but it's so easy to look at it and so easy to find on MR imaging. Let's now move on to what we're trying to do at the Brompton with Dr. Naqvi and with Fortune Rusiki, who will join in. It's called the so-called transition service from pediatric cardiology care to adult cardiology. And some interested colleagues, including myself, are basically taking care of patients at the age of 16, moving over to the adult clinic. It's organized and led by interested nurses Fortunate Rusike is one of them, and she manages this clinic in conjunction and in close interaction with Dr. Naqvi and myself. We are basically seeing the patients at the age of 16, 17, transitioning from pediatric care to adult care. And the three of us are always together in a clinic on a Friday and seeing these patients, including their mom or dad, or sometimes the whole family. And that gives them a lot of confidence and trust into the way we see these patients. We usually know the children a little bit earlier, and I can sometimes see the mother or the father in my clinic accompanied by their younger children that had been seen by Nitha, and then eventually they all kind of transition over. It's not a new introduction into a problem, it's kind of a smooth transition as it should be. It's outpatient, usually outpatient based, and additional therapies, including psychological support, counseling, of course, the advice for physical therapy and orthopedic consultation are organized in that clinic as well. The idea is, since an experienced nurse tries to lead that with the support of consultants, is to offer a complete consultation, which is documented and is basically organized according to the guidelines in the UK. Important thing, I mentioned this before, is that the whole family understand the condition and the implications. It's important to motivate them to be followed in annual or biannual intervals. This is normally not a problem because the patients themselves are so aware of their condition that they basically remind us to send them the next appointment date, and they're basically organizing their next or then their time around these important appointments in a year or in 2 years from now. Of course, other issues related to psychosocial support, health and well-being, lifestyle choices, how to engage in sports and what to do safely is important. Independent living is usually not an issue because most of them can live independently. Families are well educated and have very specific questions that are sometimes not so easy to discuss right away. And I sometimes need to prepare myself for a very thorough consultation and discussion. Of course, we discuss issues of family planning, the risks involved to transmit the disease to the next generation. This is a very common question and issue, and is discussed either with Fortunate, who is very knowledgeable in this area, or with a specific team at Chelsea and Westminster Hospital in terms of family planning and PDAs and other issues. So that's important, and I invite Fortunate now to give a comment if you are on. Why don't you just say a few words of your experience and how you perceive and how you see the patients accept that offer. Can you hear me?
Yes, can everyone hear me?
Yes.
Okay, thank you for inviting me into this platform. I have the pleasure of working with Professor Nienaber in the Marfan Clinic, and one of my roles is to transition the pediatric children to the adult service. And what we often find is these adolescent children often have a lot of questions that we normally cannot fit in a setting of a clinic. So my role is to ensure that they have that constant touch with myself, and I refer them to various people that they can always have contact with, especially when they have tricky questions to ask, when they're coming of age and they're starting to explore their sexual lives, they're starting to explore, they have relationships. So we encourage them to talk, to be free, to be open, and to discuss those things. And one of the things that I do also is to encourage people who have affected with Marfan to, once they have found an ally, once they found somebody they can trust or a partner, we encourage them to bring their partners along, and we can have a dedicated virtual appointments where we can have telephone appointments with genetic counselors, where sometimes it's not always easy to discuss your condition with a partner. So this gives them the platform to bring their partners along, and they can be open and free to discuss the difficult questions. One of also the other things that we find in young adults, they also want to know that how do they start thinking about starting a family and what support they will receive. So we also have a dedicated pregnancy and heart disease clinic, which is dedicated to pre-pregnancy counseling. And we discuss the various options that are available to people affected with Marfan's, talking through options where they can decide to have children naturally, or use a PGD, or have their embryos tested to find out if they have the gene. So they are specified, there are specific clinics that sorry, is that a question? Sorry, I thought I had something. There are specific clinics that we can refer people to, and they will be able to be involved in asking questions for family planning, and we help them along these difficult journeys. So we are trying alongside with Nitha to offer a dedicated transitioning clinic, which we don't have. But although we don't have it, it's good to let people know that I myself am available Monday to Friday, 9 to 5, to always offer support, to always support to people who think that they might be wanting to talk additionally about problems that may be facing, or when they start to go to college, what choices to make in terms of professional planning, in terms of what courses to look into. So there is that service, and we are available for them to help, even though we don't have a dedicated clinic.
Thank you, Fortunate. We are so fortunate to have you. I can't believe it. The last segment of my presentation will now involve a little bit of what Anne kindly mentioned in the introduction. I have a particular interest in endovascular interventions from a cardiology or interventional cardiology point of view, and we have extended that activity to aortic conditions. And if you're dealing with aortic conditions, of course, there will be the question whether endovascular therapy should be considered for patients with connective tissue disorders. This is not new, but there is some new experiences with it. Remember that textbook medicine prohibits endovascular interventions to patients with Marfan conditions. It's not really accepted according to guideline medicine, but the field is moving on, and there is some new developments that are worthwhile sharing today. This is a recent case report that I came across in the early times of the pandemic. It has been published, I think, in August or July, and relates to an acute complicated type B dissection in a patient with Marfan syndrome who was treated in the surge of COVID-19 in New York City. She had a real problem from a complicated dissection and presented in one of the hospitals, and they managed to get her around to appropriate care. The patient survived and did very well. This is what happened in the early times of the COVID crisis. As you can see here on the left-hand side, patients in COVID didn't present with type B or type A dissection, haven't been operated as usual. The number of cases dropped dramatically from March 20th. And as you can see on the right-hand side, it was 3 versus 12.8 before COVID in a given time frame. So dramatic changes for patients in acute danger. The similar observation had been made in our Brompton and Harefield environment. You see here in blue the incidence of acute aortic interventions per month in 2019 in blue, and in red in 2020. And you see the dramatic fall from a higher number than in 2019 to a very small number of 8, 6, and 2 cases in June. The reason for that are related to the fear of patients to present to emergency care and to actually decide and make a decision to come into hospital. Here's a case who made it to the hospital, a 34-year-old female patient with Marfan syndrome that was under my care. She was admitted at Watford DGH with an acute complicated dissection. She had previously undergone root repair a couple of years before, and now was admitted with acute problems. I saw her actually in Watford tried to get her over to Harefield for further evaluation and treatment. It didn't happen because of COVID. There was no way to get her in. We eventually got her into St. Thomas's. She was on the ITU in St. Thomas's and was managed medically initially with our guidance and recommendation. She was eventually, after 10 days, discharged home, planning for an intervention or surgical care later at Brompton or Harefield. She went home, developed further problems and conditions that couldn't be managed at home. So we got her in to the Brompton, and she was one of the first patients that was treated at the early opening of the hybrid environment in Brompton again with this complicated type B dissection. You may appreciate on the right-hand side, the left lung shows pleural effusion, blood actually in the pleural space, a truly compressed true lumen, but a still normally sized aorta, but a complicated dissection with distal malperfusion issues. The patient was then consented for an endovascular procedure, which I performed here. You see some clips from the procedure. It was difficult to find the lumen, so this image shows you the false lumen that we ended in initially. The second image now finally shows the compressed true lumen that I was able to enter. And then we moved catheters in the true lumen, the very compressed true lumen, up to the ascending aorta that you can see here, all under echo guidance. And we placed a stent graft, you see the placement here, into the dissected segment of the descending thoracic aorta and the distal arch. It's launched here. And this is the final angiographic results. And if you compare now the status before and after intervention, you see that the intervention actually could realign the complex dissection very nicely. In the center line, in the center picture, you probably appreciate the true and the false lumen and the meandering compressed true lumen, which was eventually reconstructed by an endovascular prosthesis as shown on the right-hand side with success. The lady went home after 5 days and is doing fine, no problems, no pains, no malperfusion issues. It just shows you in an example that endovascular is now entering even the therapeutic scope of patients with hereditary congenital aortic conditions. Here's another example of a patient with a dissection who was initially planned to undergo classic therapy with replacement of the entire ascending aorta and the arch, as you can probably assume here. Then a similar case is shown here, who was treated with a combination of an open and an endovascular intervention. So again, an example of the endovascular approach now entering the field of congenital hereditary connective tissue disorders. Here's a patient who was treated during pregnancy, and again, open surgery in combination with an endovascular stent graft shown on the right-hand side was able to be conducted during pregnancy. Here's a case of ours of a patient with Lloyd-Dietz syndrome. After multiple previous operations, the patient at the age of 29 refused any other operative therapy, open operative therapy, and underwent successful stenting, as shown on the right-hand side. So it just shows you that this is an option that can be offered now with improved technology and better skills, even to patients that are considered or used to be considered contraindications for endovascular treatment. Another example showing you that the total aorta can actually be managed endovascularly in selected cases. If the surgical risk is too high or prohibitively high, you have an option to offer the patient an alternative treatment. The experiences so far date about back 10 years at the most. Our own experience is almost 10 years as well, with excellent long-term results. The patient need to be looked after and seen every year and imaged every year. But I believe that this is a viable alternative to patients at a prohibitively high risk for open surgery as in textbook medicine. Here's the final example of a novel approach. You see here a patient with Marfan syndrome again and an atypical aneurysmatic formation in her left subclavian artery. You see that on the left lower corner best in a reconstruction. And next to it on the right side, you see the result a year later. After endovascular exclusion of that aneurysm, the artery looks almost normal and the aneurysm has completely disappeared. So this is possible now without open surgery, because in that particular situation, the surgeons found it difficult to operate behind the clavicle. An endovascular approach, a catheter-based approach from the left brachial artery, takes care of all these problems. And the durable result, as shown here, is obviously speaking for itself. So again, in summary, we have now more options. We can offer a personalized management in all sorts of dissection, which doesn't necessarily always mean surgery, open surgery. There is options available that hadn't been there 10 years ago, even for patients with Marfan syndrome. And I think the important thing is to be creative, to talk to surgeons, interact with them, create a plan, and execute a plan that obviously works. Thank you very much for your attention. I look forward to answer a couple of questions.
Thank you very, very much. And we look forward to working with you at the Brompton for the good of all the patients.
Yeah.
I think we have time for one question. Victoria, do you have one for us?
Nothing has emerged yet on the chat function.
Any questions? Hands up.
But thank you to Holly, who helpfully defined dura mater for those who didn't know. I'm just looking for a hand up. Let me know if I'm missing somebody. I can't. Oh, Jenny Carr, please.
I just wanted to know what endovascular means. I know I'm ignorant, but what is involved in all that?
Endovascular means the intervention is done from the inside of the artery, like keyhole surgery. No need to open the chest or to have an open access to the aorta or to the side branches of the aorta. Endovascular means you go in like a catheter procedure from the groin, and everything is done with wires and catheters. No open surgery anymore.
Thank you very, very much. I think we're going to have to go on to tea break now.
Quickly intercept.
Sorry, Victoria, yes?
Quickly, sorry. Amanda, I think Amanda Ferguson has a question. And I presumably missed her, I'm sorry.
Yeah.
Amanda, come in, Amanda.
Hello, I just wanted to ask, I had a type B dissection 10 days ago. I've been sent home to await surgery, but I was told that they would not be using an endovascular approach because it wasn't suitable for people with Marfan's.
Yeah. So you got a type B dissection 10 days ago?
Yep. And
you're now on medication?
Sorry?
You are now on medication, on beta blockers and ARBs?
Yep.
Awaiting surgery?
Yeah, I was told that I'm going to have another scan in 4 weeks' time, but they're hoping if it stays stable, they'll be able to put it off for 6 months.
Okay. Well, we have a different opinion on the approach. This is a very conservative way of judging the situation. If you wait 6 months with a type B dissection, although you're out of the woods right now, chances are that the aorta is expanding rapidly and is difficult to treat. We have defined and found a window of opportunity of about 90 days to remodel the aorta, like in this case that I showed to you, with an endovascular approach that allows the aorta to basically reassemble and remodel around the stent. The stent is basically a scaffold, and the aorta heals around the stent. That's the concept. The surgical concept is to replace the entire aorta, to cut it out and replace it by Dacron. The endovascular concept is not to cut the aorta out, but to scaffold it from the inside, leaving the tissue where it is. Just realign everything. And that seems to be working. We have excellent long-term outcome data. Once this procedure has been successfully done, the 5 to 7 year outcome is stable. There is no further late complication once it's done perfectly.
So what can I say to my surgeon?
You have to ask your surgeon about the risks of an open surgical approach. He will tell you probably that the risk of spinal complications is in the range of 10 to 15%. I'm not sure what he told you, but this is a usual figure that needs to be. There's a certain risk of serious complications during the operation, besides the spinal complications that can arise. And you have to compare that to the risks involved in the endovascular approach. The endovascular approach has a very low risk of spinal complications because we don't interrupt the spinal arteries. We just realign the tissues and leave the aorta in place. The mortality of the procedure is around less than 1%.
Okay. I was told that there's kind of a high rate of breakdown or failure of endovascular repairs of type B.
Yeah. This is what the textbook medicine tells everybody. If you read a textbook, which usually summarizes information from 5 to 10 years ago, you get this impression. But I used the opportunity here to open the scope up to just to explain that there's multiple options. And one of them is a newer generation of stent graft with very low radial force. They're very conformative and they're very flexible, and they even can be used in delicate tissues like in patients with Marfan syndrome.
Okay.
So we would not exclude that option. Let's put it this way. If you want a second opinion, you have to show me your images and we can discuss it. It's also a matter of anatomy. Sometimes the anatomical features do not allow an endovascular approach, but often it is possible and get excellent results.
I think from what they said that my dissection is a not particularly severe one. It went up the way, so from just below my diaphragm, it dissected actually up the way, stopped just below my left subclavian and went back down again in a kind of loop. But it has already, it's already clotted. It's already, so the blood is now running through where it should be running through.
So you have a clotted false lumen, is that what you're saying?
No, it's actually running, the blood is now running through the correct lumen.
So the false lumen is clotted?
Yes.
Entirely clotted, or?
I think they said so. They said the blood is now running where it should be running.
Okay, but if the false lumen is entirely clotted, you don't need surgery.
Oh.
Perhaps we should leave you two to continue your discussion.
We have to, I mean, if you really want to look into that carefully, we have to meet and you have to show me the images. But I'm just telling you there's options.
Okay.
You could ask for a second opinion.
Yeah.
Ask to be referred down for a second opinion. Or could you do that remotely? Could you see the images? Share the images with the first surgeon?
All my images are on the national database. I don't know if that's National Scotland or National UK, but I know that they are on the national database.
I'm sure something could be arranged.
I don't think that your images, the CT images, will be put on a national database. I think the information will be confined in the server of your hospital.
No, in Scotland, I mean, maybe it's in Scotland, but because I was in a different hospital from where I had my original surgery, but they were able to access all my previous scans. I was told they're on the national database.
Okay. So you underwent previous surgery before that happened?
I had aortic root replacement and valve reimplantation 12 years ago.
Similar to this patient, yeah.
Yeah.
Well, you're welcome. If you want to contact me, I'm happy to look at your scans and then we take it from there.
Thank you very much.
Thank you very much, Christoph. And you've obviously given us a view of the future, which is what we badly need.